YouTube. So will it help?
Yes, ma'am. I'm putting this in the group that it is live on YouTube also.
Yeah, I think that will matter.
But for YouTube link, the same link will
I'm
work.
sharing, ma'am. Just it is getting live. I'm sharing.
Okay, okay, okay.
It is live on YouTube, ma'am.
Okay. मेरे ख्याल में बाकियों को म्यूट कर दो, बस जो बोले तो that would be better.
This is Ranjit Sahu, Head of Marketing with Walter Bushnell. Welcome you to a lovely Friday evening. So, Uttar Pradesh chapter of Obs and Gynae present you with this Menopause Committee webinar. The topic is very relevant. It's privilege to get old. With this, I hand over the session to Manju Verma ma'am to take it forward. Manju ma'am, over to you.
थैंक यू माय मेरा सबको प्रणाम कर रखा है, उसको म्यूट कर रखा है।
कहीं सुनाई दे रहा है?
ओके ओके
ऑडिबल मैम।
मेरा सबको सादर प्रणाम, जितने भी लोगों ने ज्वाइन किया है। आई रियली वांट टू से थैंक यू टू देम एंड डॉक्टर राज बवेजा इज अनेबल टू जॉइन एज येट, सो आई वुड लाइक to go forward, and here I would like to definitely welcome the stalwarts of the UPCOG. That's Dr. Padam Shri Professor Usha Sharma, Madam. Says the CV of Madam Usha Sharma, and we know we really respect you. We know we really Usha ji ka CV.
Please display the CV.
Please display the CV, madam.
Yes, Farooq, please display the
Yes,
CV.
I am doing.
Okay.
Next.
Hey, Dr. Baija is not there, is unable to join. The girl has gone
next
to to help her out. So we pass on to the next person. The next chief patron of UPCOG, Usha ji. I cannot read your CV. I think it really is कि सूरज को दीपक दिखाने के बराबर है, तो मैं सिर्फ इतना ही करूँगी।
जरूरत नहीं है।
That we bow to your energy, which you have, and the other thing I would like to say, and I think everybody is going to, agree with me that you sweat glitter. So I would like to have words of blessing for the webinar today.
Thank you very much, Manju. I hope I am audible.
Yes,
Okay,
ma'am.
Okay. First of all, I must thank the organizers as well as the representative from Walter Bushnell, Mr. Ranjit, and other representatives who have really helped us a lot for technical support. Today we are going to have the seminar of Menopause Committee, which is being led by a dynamic leader, Dr. Manju Verma, and co-chairperson of this committee is Amrita Chaurasia. Then we have members Veena Gupta as well as Ramit Ahuja. And today we know that this UPCOG, iski to shaan hamari president Dr. Anuradha Khanna hai, और जो सबसे ज्यादा जिनकी मैं indebted हूँ for this UPCOG is my real guide and leader, Dr. Chandravati and Dr. Meera Agnihotri, who are with us today. Unfortunately, Dr. Raj Bhavija has not been able to log in. And then we have got Vice President Kirti and Seema Hakim, Secretary, of course, a very dynamic, hardworking Dr. Bharti Maheshwari, and Joint Secretary, Dr. Priyanka Garg, who everybody knows is a young and a very, very dedicated person. Now, as we know that Menopausal Committee is supposed to organize a webinar on menopause, and when I just read the topic of the webinar, it's a privilege to get old. Manju, tune mera khoon badha diya. Mujhe laga, are wah, I am the privileged person because it's a privilege to get old, and I am really old. All of us know that previously menopause was supposed to be the problem of later half of the life, but with the increasing longevity of a lady as well as of a male, now it has become a midlife crisis. And then the concept of itchy, bitchy, menopause, dwarf, which we used to say, has been overcome by the concept of you have to aging with grace, with independence, and with perfection. And so today we know that we are having a very good discussions for the breast lesions, conundrum of breast lesions. And the speaker is none other than our great Dr. Divya Khanna. And I was very happy to know that Divya is a gifted daughter of our dynamic, dedicated, knowledgeable, proud mother, Dr. Anuradha Khanna. And she is from BHU and she will be speaking on breast lesions. All of us know that breast cancer is one of the commonest cancer of the females, and usually it happens around 50 years. But these days, even in younger age, also less than 50 years, you can have this. And it's very good that it has also been a part of PG curriculum. And I think it's very, very important for every gynecologist to know how to screen, how to diagnose, how to prevent, and the various treatment modalities of breast cancer. I am sure that the deliberation today will go a long way in updating the knowledge of each and everyone who is present here and is attending this webinar. Manju, I will certainly like to congratulate you. Dear, I can tell you that you are so systematic and so persuasive that all the time you are getting it, you are giving it in every group. And I don't think any member of UPCOG you can miss. You have conveyed this program that to every member, and especially the credit goes to our President Anuradha also, because Anuradha and Manju, this is a joint effort. And I'm sure it will be a very, very successful webinar. I wish this program a great success, and I wish you all a very healthy, happy, and bright future. Thank you very much, Manju, once again for organizing such a wonderful webinar. And I hope that everybody will like it. And especially, I'm so happy that today we are here with our great leader, Dr. Chandravati, and a great persuader who has always helped me to take this UPCOG forward, Dr. Meera Agnihotri. Thank you very much.
Thank you, Ushaji. Thank you all for your words. You know, they really encourage us for do everything in the for women. You have sacrificed all your life for the welfare of women, and I think we may be able to carry the path forward. And now I would like to request the CV of Professor Chandravati. I mean, Chandra ji, अब चंद्रा जी का फोटो लगा दीजिए ज्यादा. मैं आपका सीवी नहीं पढ़ रही हूँ क्योंकि सीवी बहुतों को मालूम है आपके बारे में, but I would definitely like to say that you are a wonderful person.
Yes.
You know, and you know, you are perfect. You are perfect, and the positive attitude in challenging situation one can learn from you. So the chief patron Chandraji, patron Chandraji, I would like you to bless for this webinar.
Manju, I think तुम दिन बना देती हो क्योंकि तारीफ करके मुझे थोड़ी देर में ही लगता है कि you know you are
हम भी कुछ है
पर ऐसी कुछ बड़ी चीज नहीं है. मेरा काम हमेशा इसलिए आसान होता है because उषा is there. तो उषा सब पूरी कहानी बता चुकी होती है और मैं उसके बाद बस एक फॉलो ऑन करना होता है कि मुझे बेस्ट ऑफ विशेस देनी होती है. I must really congratulate you for choosing the topic and choosing a very beautiful way of getting old, because मेरी head doctor engineer कहा करती थी one should learn to age gracefully. So I think each one of us have learned that to age gracefully, but now we have to live beyond that even, and that grace needs to be continued, that you know, positive attitude needs to be continued. And I think there's nothing else in life except that you must be positive what you are doing. Every day is a new day. Every day is a beautiful day. And we must look for the next day with all the hopes and beautiful things. Congratulations for choosing this subject. I must congratulate Anuradha for having such a learned daughter who's going to talk today, and we'll be listening to her. Wish you all success for this wonderful webinar today and choosing this wonderful topic of breast lesions. I'm sure it's going to really benefit for all this audience, all the participants who have joined through this webinar. So Manju, keep up, do it again and again. We are all there to be with you all the time. Thank you.
So sweet of Chandraji. We always want you to be with us. May I have the CV of Dr. Meera Agnihotri? Meera ji, I am really genuinely say thank you from my heart that you have joined. And I know you are a wonderful person. Everybody has said so many things about you, and I know that you are a wonderful person. And despite your such a busy schedule, with Meera ji is going to be felicitated tomorrow by the Ram Govind ji tomorrow. Yet she has taken time to come and join this webinar. Meera ji, we want your blessings for the webinar. Meera ji. Hello.
Hello, Manju.
Congratulations for the
Yes.
you are being felicitated
Advance.
tomorrow.
In
Manju,
advance.
it was a rehearsal parade because there is a routine that a parade has to be made. कौन कब जाएगा, कहाँ से उतरेगा, कहाँ से ये. So it's okay. At the outset, I really congratulate my dear Manju and Anuradha for making me a part of this August gathering. And it is always an honor to share the dais with so big giants, my friend, philosopher and guide, Usha ji and Chandra ji. I just feel that I am elevated. That is all. It gives me a feeling of elevation being with them. Manju, the subject which you have chosen is really wonderful. I believe Usha ji and Chandra ji must be remembering that Menopause per oration mujhe diya tha long back, and that was being delivered in Aligarh, I believe.
Yes.
And I still stand for the same. Aging is just a number. You become senior every day, and your desire for work increases. So long we have worked for society, everything. Now we have to just get back what we have gained so long. So aging gracefully is a very important thing. And as Usha ji and Chandra ji have told, that we really feel honored that we are getting age, but we will not count numbers. We will be counting our works, what we have done for the society. Usha ji has already taken a name of all the persons present over there. My lovely friend Anuradha Khanna, and it is very dashing statement that her daughter, whom I met long and I just know her since very young age, and she will be delivering the lecture. It's very delighting and really prestigious for all of us. My dear Kirti, Seema, and Bharti Maheshwari, Priyanka, congratulations for being with us. Now, Menopause Committee headed by Manju, Amrita, Veena, and Ramit Ahuja. I know that Manju, whenever she plans something, तो जिसको ठान लिया तो ठान लिया. और इतना मेरा सब होने के बावजूद मंजू ने कहा मीरा जी देख लीजिएगा. तो लास्ट सेंटेंस तो जो शुरू का तो सब याद नहीं रहा, बाद का मुझे याद रहा कि देख लीजिएगा. तो मैंने समझ लिया कि मुझे देखना है ही. So I am here, or I will be going just after it because rehearsal will continue up to 7 o'clock, I was told. Anyhow, subject is wonderful and chairpersons are more than that. Manju Shukla.
Yes, I forgot the name of chairpersons. हमारी मंजू, रंजना और अब वो तो शायद आज आई नहीं है.
नहीं, Manju is there.
मंजू और रंजना है.
Manju and
Radha has not been able to come.
Anyhow, Manju and Rajna,
great
they are
chairpersons,
really, dynamic beauties with brains. I always call and
thank you so much.
Call these beauties because अगर ये दोनों हमारे तरफ हैं तो हमें लगता है हम भी थोड़े सुंदर हो गए हैं. Anyhow, and I congratulate Divya for being with us. Once again, I congratulate Dr. Manju, Anuradha, and all the chairperson for making this wonderful webinar, a memorable webinar with a number of back home messages which they will carry. And menopause is just a pause of menstruation, menopause, but does not stop anybody for any other action. That is all. I can see Kirti also. Kirti has joined.
Yes.
Kirti, love you. These words, I'll be here again for 5 minutes. And I believe Usha ji and Chandra ji and Manju and Anuradha will allow me to go into a beautiful parade which they are planning. I don't know how to enter, how to get down, when to sit and just like that. So please allow me.
Congratulations, madam.
Congratulations.
Congratulations.
Heartfelt congratulations, Meera.
Congrats, madam.
Very, very thankful to you. I would like to say that हम लोग को सीखना चाहिए अपने इन्हीं चारों लोगों से, उषा जी and चंद्रा जी
कोई इको हो रही है
and मीरा जी.
ये क्या आवाज आ रही है?
बैकग्राउंड म्यूजिक है वो.
वो ये कह रहा है क्योंकि मैं कहने जा रही थी कि उम्र को हराना है तो शौक जिंदा रखिए, चले ना चले.
तो डिस्को शुरू कर दिया क्या?
नहीं पता,
मन उड़ता परिंदा रखिए. तो
मैं तो अभी दोबारा पैदा हुई हूँ, इसलिए मैं तो न्यू बॉर्न हूँ.
बिल्कुल.
आप लोगों से हमने यही सीखा, एज इज जस्ट अ नंबर एंड वी हैव टू always positive. We really एक अंगूर की कीमत कम होती है, किशमिश की कीमत ज्यादा होती है. तो we are in that group. So now I would like Dr. Veena Gupta to take over. And Dr. Veena Gupta, are you there?
वीना मैम अनम्यूट करिए अपने आप को.
अभी तो थी वीना, थी तो
अमृता या रमीत,
ये है तो वीना.
है.
Good evening, everybody. And it's my pleasure to welcome the office bearers of UP Menopausal Committee.
Your voice is not clear, Veena.
ये वीना के
आवाज नहीं आ रही,
म्यूजिक आ रहा है.
पास से बोलो.
आवाज नहीं आ रही है?
नहीं, तुम्हारे पीछे से बैकग्राउंड बहुत,
तुम्हारी आवाज के साथ बहुत कुछ आ रहा है. और
कुछ भी तो नहीं है मैडम यहाँ पे.
नहीं, अब आ रही है, बेटर है, अब बेटर.
मैं तो चेंबर में बैठी हूँ.
अब ठीक है.
ठीक है. So good evening, everybody. Now it's my pleasure to welcome the office bearers of Menopausal Committee, and I would like to welcome first Dr. Anuradha Khanna. Ranjit ji, may I have the CV of Dr. Anuradha Khanna?
Yes, ma'am. Yes.
We all know madam because she is a professor and head medical college.
हो गया.
Pharmacy.
Anuradha is there with all of you.
And at present she is president of UP Menopausal Committee. Madam, we need your blessings. So I would request to say a few words to bless us. Madam Anuradha, madam, please.
मेरी blessings नहीं, मुझको blessings की जरूरत है. I'm so obliged, Dr. Manju Verma ma'am, that you have taken this topic as a lecture in the UPCOG 2023, and I'm having our chief patron, Madam Usha Sharma, and our emeritus professor, Dr. Chandrati ma'am, and also our eminent Dr. Meera Mutri ma'am, and Dr. Manju Verma. तो बस पूछिए मत, इनकी knowledge, इनका इतना प्यारा एटीट्यूड हमारे लिए, वो इतने स्वीटली इनवाइट करना, अनुराधा देखो ये टॉपिक रख लें तो कैसा है, दिव्या बोल दे तो कैसा है. शी इज सो नाइस, डाउन टू द अर्थ, कि जितने भी वर्ड्स हैं वो कम है मुझे मैम को अप्रिशिएट करने के लिए. और जितने भी हमारे चेयरपर्सन हैं, डॉक्टर मंजू शुक्ला, डॉक्टर रंजना, आप सब मेरे वेरी मच क्लोज टू द हार्ट. अमृता जी, आप तो हैं ही बहुत हमारी प्रिय. साथ में हमारे ऑफिस बेयरर्स, डॉक्टर कीर्ति जी, आई कैन सी. सो मैं ब्लेसिंग्स तो मुझे लेनी भी है, देनी भी है. And I just want that our UPCG have a very long life, and जितने भी dreams हो सके हम fulfill करें. Thank you very much. Thanks for everything.
Thank you, madam, for your kind words. Now I would like to welcome Dr. Kirti Dubey, madam. May I have the CV? Madam is President, Meerut Obstetrics and Gynae Society, and she is Vice President of UP Menopausal Society. And she is ex-principal come Professor NL Agam Medical College, Meerut. Now, can I have the CV of Dr. Seema Hakim? Dr. Seema Hakim, as present, she is Professor and Unit Head, AMU, and she is Vice President of UP Menopausal Society. And so many appreciation awards Madam has. Now the next, Dr. Bharti Maheshwari. She is Professor and Head Department of Obstetrics and Gynae. She is Chairperson of FOXI NTP Committee, and here she is Secretary of UP Menopausal Society. Then next, Dr.
नहीं UPCOG की यार
UPCOG,
Vice President
है
Menopause Society की तो हमारी मंजू वर्मा है लीडर.
फ्लायर में वाइस प्रेसिडेंट
नहीं वाइस प्रेसिडेंट UPCOG बेटा.
सॉरी मैम.
अनुराधा प्रेसिडेंट है और ये दोनों वाइस प्रेसिडेंट.
कीर्ति and Seema are vice president.
Yeah, the vice. Oh, sorry ma'am. Sorry.
No problem. Go ahead.
Then I welcome Dr. Priyanka Garg. She is Joint Secretary UPCOG, and she is Consultant Obstetrics and Gynae and Endoscopic Surgeon at Meerut. Madam, I would like to request all of you to please give your valuable comments after the session. Now I hand over the mic to Dr. Amrita Chaurasia to proceed for the scientific session. Dr. Amrita, please.
थोड़ी सी मंजू इको आ रही है.
हाँ, बहुत ज्यादा आ रहा है. अमृता अनम्यूट करो.
ये जब वीना का ऑन हो रहा है तो क्रीचिंग साउंड इज देयर.
किसी का था.
हाँ,
तुम्हारा
मेरा वॉइस क्लियर है.
हाँ, क्लियर है.
Yes, ma'am. Thank you so much, and a very good evening to all the dignitaries, seniors, and my dear friends who are here for the webinar today. And just my resident has called that Baveja madam is joining. She has gone to her place, and now she is with her, and she is trying to join her to the webinar. So as soon as she joins, we will have her blessings.
Yes,
In the meantime, we move forward for the scientific session. Yes, ma'am. So today's topic of the scientific deliberation already have been discussed by our seniors. This breast lesion is actually not a part of obs and gynae, but being a problem of a female population, these all patients, they come to us as the first consultation. And they want us to treat her like, because they don't want to go to male surgeons. But then whatever it is, we must have a basic knowledge about the breast lesions, what to do, when to refer, and what to counsel them and what to suggest them. So we are having today's Dr. Divya's lecture on that only. So it will be very informative for all of us. And we have chairpersons. I would like to invite our chairpersons for the scientific session. May I have the CVs of the chairpersons, please? Both the chairpersons, I must say, they are well known, but the main thing that describe them is ever smiling face of both of them, Dr. Manju Shukla madam and Dr. Ranjana Khanna madam. Manju Shukla ma'am is such a lovely person, lovable, lively, pleasant personality, and whenever she is around, everybody is laughing only. So this describes her personality. Otherwise, everybody knows that madam was.
मेरा सीवी क्यों लगा दिया?
मंजू वर्मा का सीवी.
Manju Shukla ma'am.
शुक्ला जी का, मंजू शुक्ला.
Madam was professor in the Department of Obs and Gynae. Yes, ma'am. Again, vibrant picture is there. So welcome, madam, as the chairperson for today's scientific session. Next chairperson is Dr. Ranjana Khanna. She is again ever smiling, having great energy, always oozing positivity wherever she is. So, and madam is also, I think, contesting for upcoming elections in the FOXI. So we all wish you best luck, and we invite you as a chairperson for the today's lecture. Now I would request Dr. Ranjana Khanna, Dr. Manju Shukla ma'am to introduce the speaker.
स्लाइड लगवा दो.
हाँ जी मैम. डॉक्टर दिव्या की स्लाइड लगाइएगा प्लीज.
Thank you, Manju, for involving me. And after such a boring 1 month of my illness, I feel so good.
Very
So,
good.
and it is my proud privilege to introduce Dr. Divya Khanna. She is daughter of one of our colleagues. And
मैम म्यूट हो गया है मैम
मैम म्यूट हो गया आपका
म्यूट हो नहीं
आपका
आ गया आ गया आ गया आ गया
अब आ गया अब फिर म्यूट हो गया मैम फिर म्यूट हो गया है हाँ
तुम लोग करोगे शुरू करोगे
अच्छा।
म्यूट करोगे शुरू करो यही होगा
ओ राज जी नमस्कार।
राज जी
राज जी नमस्कार।
उषा जी आपके दर्शन हो रहे हैं मुझे बहुत
आए
अच्छे
रे राज जी, बस
आई एम
पूछिए
सो
मत।
हैप्पी टू सी यू
आपको देख के खुश हो गए बिल्कुल।
अरे हम आपको देख के खुश हो गए
मैडम नहीं आती
Thank
तो
you.
इलाहाबाद नहीं रिप्रेजेंट होता।
अरे
हाँ।
प्रणाम सलाम
यस मैम नमस्ते मैम
सलाम
नमस्कार मैम
सलाम सलाम
चलिए,
सलाम गुड
रौनक
मॉर्निंग
बढ़
गुड
गई।
आफ्टरनून
मैडम
good evening to everyone who is there and good evening to a person who has come to over here. She's sitting next to me and see her now. Hello karo.
नमस्ते she is Anjali senior resident my senior resident
Yes, yes.
She's a postgraduate student who has been there assigned to come to my house to pick me up, not to pick me up, rather
Yeah.
to come
Assist
over
you.
here and start
To-
me.
आपका
To help
फोन
you
नहीं
to
मिल रहा
log
था
in.
बड़ा
What, what?
मुश्किल।
I
आपका
want to
फोन
hear this. Divya Sharma, Divya Khanna.
Yes.
Divya,
दिव्या
हाँ,
I think I hear you somewhere. You are from
BHU.
Agra,
BHU.
हैं?
अनुराधा की
आगरा के
बिटिया
वाराणसी
है।
बोलो ना
Madam, I am
दिव्या
from,
दिव्या
Madam, I am from Tata Memorial
दिव्या जी
Center, which has been established in Varanasi in 2018 onwards.
चलो तो हम बता
Well,
दें
I
दिव्या, ये
really
Preventive
कैंसर है।
oncology.
She is cancer
God bless
specialist.
everybody. God bless
Thank
and
you.
have a nice day and a
Thank
nice
you.
evening. We are going to hear a wonderful lecture now by Dr. Divya. Divya, I'm very happy to see you, although it is a photograph that I'm seeing at the moment.
She is
And
associate professor and office in
yeah,
charge in oncology Tata Memorial Center, Varanasi. She is investigator in various cancer registry and population-based cancer screening projects, Varanasi. She is master trainer, medical certificate of course of
death
US COD and CCE. She is an editorial board member, Cancer Control Journal. 30 national and international publication to her credit. She is peer reviewer for the international journal, the BMJ and BMC, Women's Health,
वो
SAG,
पूरा नहीं है असल में ना इधर।
International Journal of Epidemiology, BMJ Medicine, and International Journal of
Behavioral
medicine.
Education, etc. So she is very learned and she is cancer specialist and going to talk on benign breast diseases. Divya, the stage is yours.
Thank you so much, ma'am. And ma'am, this is
आवाज म्यूट हो गई।
हो गई आवाज गई नहीं म्यूट नहीं
आवाज
हुआ।
गई दिव्या। दिव्या आवाज गई।
ब्रिजेश जी आवाज देखिए नहीं आ रही है।
शायद दिव्या का नेटवर्क का प्रॉब्लम
हाँ ठीक है।
yes, ma'am. So, ma'am, shall I share my slides now? Can I?
Yes, yes.
Permission? Yes, ma'am. Thank you so much. I think मेरे को permission चाहिए होगी slide share करने की. Yes, I can. Got it. Thank you. Ma'am, I hope the presentation is visible to all in a slide share mode. Yes, ma'am.
Make it full screen, ma'am. Yes, now it is visible.
Yes, now it's fine.
Thank you so much. So the topic for today is the conundrum of breast lesions. And the objective of this presentation is to describe the spectrum of breast lesions, how to approach a woman with breast lesions, and some take-home notes for any physician. We know the spectrum of breast cancer ranges from benign to malignant conditions. And the benign conditions include developmental abnormalities, inflammatory conditions, proliferative conditions, and benign breast tumors. And we are also dreaded about the breast cancer. Benign breast disease is a heterogeneous group of lesions that may present as a wide range of symptoms, but can also be detected incidentally. And this incidence of rise for this benign breast disease is seen for around the second decade of the life, and it peaks in the fourth and fifth decade of the life. While we know that the malignant breast disorder, malignancy of breast is dependent upon the age. Age is an independent risk factor, and as the age of the woman progresses, the likelihood of developing breast cancer keeps on increasing. The benign breast disease are very common. In fact, 9 out of 10 cases that we see in our routine settings, in our routine outpatient settings with breast complaints are benign breast disorders. But the problem is that it is the understanding for the benign breast disease is still very poor, and they are many a times poorly managed. In fact, there was hospital-based study. There have been several hospital-based studies to understand the spectrum of benign breast disorders. And it was seen in one of the studies from Banaras Hindu University that breast pain and nodularity was the leading form of manifestation of breast disorders, followed by fibroadenoma, phylloid tumor, ductal ectasia, duct papilloma, gynecomastia, and even tuberculosis. But when we go to a surgical oncology unit, there it is seen that almost 1/3 of these patients will present with malignancy. This is a study done of over 8,000 breast biopsies that were done in a Rajasthan Medical College, and it was a tertiary oncology center. It was a tertiary oncology surgical unit, and what they found was that 1/3 of them were breast cancers among all the breast disorders. So what I learned from when I was preparing this presentation, I went through several hospital-based study settings that have been done in Indian context. And what I found was the proportion of breast cancer among the breast diseases ranged from 1% to as high as 40%. And this proportion actually was dependent upon the type of the health center, whether this health center was a tertiary oncology center or whether it was a general surgical unit. And where was this center located, whether it was located in an urban setup or whether in a rural setup, and in which tier of the city it was located. What we found and what I found during this preparation, what I found was the metropolitan cities such as Hyderabad, Delhi, Mumbai, there the breast cancer proportion was much higher compared to second and third tier cities. And even the kind of studies where what was the basis of diagnosis for those benign breast disorders, whether it was a radiological basis or whether it was a pathological basis or biopsy basis study was there. So wherever there was a radiological basis of diagnosis, benign breast disorders were more in proportion, because we know generally the benign breast disorders are not taken further for a biopsy. But in a setting where biopsies were reported, more of breast cancers were seen, because probably the surgeons are going to refer the breast lesions for biopsy if they find it suspicious. And generally, the benign breast disorders do not require surgery, and in the form of imaging and in the form of biopsy, in the form of co-needle biopsy and fine needle aspiration cytology is all required to make the diagnosis, and surgery is not required for the diagnosis confirmation. And the general management of benign breast disorder is in the form of clinical and radiological investigations, followed by co-needle biopsy to rule out malignancy, to provide palliation of the symptoms, because these patients are very apprehensive. They have their complaints, which can be incapacitating. And basically very important to counsel and reassure these patients. And a very important part is that when the woman is there with a benign breast condition, but increased breast cancer risk because of various reasons, which I'll show in the coming slides, monitoring of these patients is very important. A regular follow-up, a short interval, or a regular 2 to 3 year interval follow-up is very much required in such patients. So during these slides, I'll initially describe about the specific benign breast disorder abnormalities, and then I will go towards the diagnostic approach. So they are developmental abnormalities. And in developmental abnormalities, we commonly see is ectopic breast tissue and nipple, and maybe supernumerary breast tissue and nipple. And this is mostly seen along the milk line, in the chest wall, in the axilla, and even in the vulva. And rarely this ectopic breast tissue and nipple is also found, in fact, on the sole of the foot, in the knee, in the thighs, in the buttock areas, even face, ear and neck areas, we can find this ectopic breast tissue. But why do we want to identify these ectopic breast tissues? We want to identify them because they can serve as a milieu for not only benign breast disorder conditions, but also for malignancy. And it is reported that ectopic breast tissue is more prone to malignant changes, and these malignant changes can happen at a very early age, at an earlier age. The other developmental abnormality is in the form of macromastia, which is the breast hypertrophy. It could be in the form of hypoplasia, which can be congenital or acquired. It can be amastia, where there is absence of nipple and breast tissue. Amasia, where there is absence of breast tissue. Athelia, where there is absence of nipple areolar complex. As you can see on the left side, this is a virginal hypertrophy, a young girl presenting with giant breasts, macromastia. And such women, young women should always be, they can be always a differential diagnosis in the form of bilateral giant fibroadenoma. So that is why when we find such females, it becomes very important to rule out any fibroadenoma which may have malignant potential. Another anomaly is in the form of tuberous breast. Ma'am, is my voice echoing? Any problem in my voice?
It's all right. Okay. We can hear you. Yeah.
Yes, ma'am. Thank you so much. So there's another anomaly in the form of tuberous breast, where the lower pole of the breast tissue, as you can see here, the lower pole of the breast tissue is lacking, and the nipple areolar complex is very prominent. Many girls come with such breast and they need only in the form of reassurance. But I want to also emphasize that breast hypoplasia, especially if it is congenital, it can be related to syndromes such as ulnar mammary syndrome, Poland syndrome, Turner syndrome, and congenital adrenal hyperplasia. And it is reported that ulnar mammary syndrome and Poland syndrome have an increased risk and are linked with breast cancer. Then there are inflammatory conditions in which very commonly, it's a very common finding that we see in our routine settings. It is acute mastitis, which happens during the first 3 months of postpartum. It is also called as puerperal and lactation-led mastitis. And the reasons is improper nursing technique, or sleep deprivation and stress to the mother, lactating mother, or maybe the combination of both. And generally, they develop breast abscess, which can be drained and can be aspirated and further managed. But it is also very important to know that the mastitis can also mimic with the condition called as inflammatory breast carcinoma. In fact, if you see the breast dermatitis, mastitis, Paget's disease, and inflammatory breast carcinoma can have very similar clinical picture, especially this pudy orange, which is very commonly seen in all of the 4 conditions. Then there is granulomatous mastitis, which is a chronic inflammatory condition of breast where etiology is not known, but it is said that the milk proteins, woman develops autoimmune response towards her own milk proteins. They can be bacterial infection in the form of Corynebacterium. It can be because of hyperpolitinemia as well. But the granulomatous mastitis needs to, when we are seeing such a case, the differential diagnosis for granulomatous mastitis is very important: tuberculosis, sarcoidosis, Wegener's granulomatosis, histoplasmosis, actinomycosis, and especially in the present scenario, the breast augmentation, which is done, which leads to silicone breast implants, which can cause foreign body reaction in the form of siliconomas, traumatic fat necrosis, and of course, inflammatory breast cancer. So when a patient presents with granulomatous mastitis, it is generally unilateral. It's a painful mass associated with erythema. There can be abscess in sinus. There can be associated pudy orange condition. There can be nipple retraction with axillary lymph nodes. And often we may find systemic conditions in the form of erythema nodosum, where we can find multiple red inflamed nodules throughout the upper and lower limbs or to other parts of the body. And maybe we can find the other systemic manifestations in the form of uveitis, splenomegaly, asthma, joint pains, arthritis. So maybe mastitis is just one of the manifestation of such a systemic disease, and we need to rule them out. And on imaging, the mastitis may resemble also with inflammatory cancer. It may have asymmetry, it may have skin thickening with axillary lymph nodes, with heterogeneous echoic conditions, which can be in the form of irregular masses, and maybe MRI may be helpful in differentiating. But generally, core needle biopsy is the investigation of choice to rule out malignancy, especially from these mastitis conditions, where we want to ensure that malignancy is not there. And in granulomatous mastitis, what we find is generally a non-caseating granuloma along with lymphocytes and plasma cells. This is a report on mammary tuberculosis, and we know that mammary tuberculosis is common in our Indian settings. They can present with breast lump, with or without sinus, with nodularity, with axillary lymph nodes, and history of previously poorly managed cold abscesses. And in tubercular mastitis, generally these patients have MON2 test positive, their ESR will be raised. They may have primary chest tuberculosis as well, but it is also important to tell here that the discharge that is coming from these abscesses are generally Z-Lensin staining negative. In fact, in only 12% of the females, acid-pass bacilli is seen, and in rest of the patients of tuberculosis mastitis, we may not find acid-pass bacilli. And on a biopsy, we may find caseating granuloma with Langhans-Giant cell, and that is enough for diagnosis. Especially in our settings, where tuberculosis is endemic, we should start the treatment once the biopsy shows caseating granuloma and start treatment for probable tuberculosis. Should not wait for the acid-pass bacilli stain getting positive or even the culture reports. And also biopsy is important to rule out coexisting carcinoma. The other inflammatory condition is in the form of mammary duct ectasia, also called as periductal mastitis. And this also mimics invasive carcinoma clinically. In fact, these patients are generally middle-aged female who are elderly, they are paras, they come with nipple discharge, maybe a palpable subareolar mass with non-cyclical mastalgia and even nipple inversion or retraction. In fact, if you can see on the right side, this transverse retraction of the nipple, it's also called as transverse squeezing of the nipple. It is a very pathognomic sign of mammary duct ectasia. Generally, it is said that young women who smoke are prone to develop this condition. It is also important that this is not associated with breast cancer, and on histopathology, we may just find that just major ducts are dilated and there is inspissated luminal secretion that are collected in those major ducts, dilated ducts, and patient may also present with brownish nipple discharge. Another mimicking condition is traumatic fat necrosis, which occurs in the form of inflammation of the adipose tissue. And this traumatic fat necrosis can happen because of accidental trauma due to various reasons. In fact, we see so commonly young lactating mothers where they say that probably the baby, I was feeding the baby, there was a bite was there because of the feeding. They are feeding the child over 2-year-old, or maybe the child has playfully, kicked the mother at the breast and they develop traumatic fat necrosis. It's a very common finding in our settings. And even after surgery, also traumatic fat necrosis develops. On inflammation, it is seen there's basically liquefaction of the adipose tissue and finally fibrosis. And if you can see on the right side, the fat necrosis resembles very much like a malignancy condition. The other abnormalities in the form of proliferation abnormalities of epithelium and stroma. And the most important name that comes out is the fibrocystic changes, which is the most frequent benign disorder of the breast. And it is also called as fibroadenosis, fibrocystic disease, cystic mastopathy, chronic cystic disease, and so on. And in fact, this fibrocystic changes happens in the age group of entire span of 20 to 50 years. And clinically, what patients we find, almost 50% of them are basically fibrocystic changes. And in fact, on histology, when we send the patients for biopsy, if we feel that biopsy is required in such conditions, 90% of them come out as fibrocystic changes only. These fibrocystic changes are generally multifocal, they are bilateral, they are associated with breast pain and tender nodularity. And the reason it is because of the estrogen predominance over progesterone. Pathologies in the form of macro and micro cyst, and they can be also adenosis, metaplasia, hyperplasia, radial scarring, and papilloma. So DuPont and Page classified the fibrocystic changes into three categories: the non-proliferative, the proliferative with atypia, and the proliferative without atypia, and the proliferative with atypia. Here, I just want to emphasize through this slide is that the patients who are coming to us with the histopathology report of proliferation with atypia, there the breast cancer risk can be as high as 13-fold. So it is very important for us to ask the patient for previous histopathological findings of any lump excision that was done in past. The good news is that about 70% of the biopsies that are done for fibrocystic changes, they come with non-proliferative lesions. And the other good news is that even this atypical hyperplasia, though it has increased risk of breast cancer, 80% of them will not develop invasive cancer in their lifetime. So, but they do require follow-up. And this atypical hyperplasia, I just want to emphasize on this, especially my take-home message for this presentation is atypical hyperplasia. That when we are getting a condition such as atypical hyperplasia, it is basically abnormal epithelium proliferative breast lesions that are not qualitatively or quantitatively abnormal enough to be classified as carcinoma in situ. It is basically a pre-malignant condition of breast, and it can happen in both ductal or lobular epithelium. It can range from 5 to 20% of the breast biopsy that is happening in a clinical setting. And surgical excision after the diagnosis of atypical ductal hyperplasia is the standard of care, but it will be decided only after the shared decision-making between the clinician and the patient on the basis of the overall clinical picture. And it is very important that such patients should have short interval of follow-up. Surveillance is an absolute must in such patients. And just coming to the this is a natural history for, in fact, it is a kinetic modeling data that was created showing that it takes 10 to 20 years for atypical hyperplasia to convert into a clinical detectable tumor. I know you all must be relating it with cervical cancer, where there is a pre-cancer condition and it takes 10 to 50 years to develop cancer. This is very similar to this, but it is difficult to find in breast this pre-malignant conditions, because many a times these patients do not report to the health setting. They are not able to palpate any lump. While in pre-cancer or cervical cancer, such patients can be easily screened and treated completely. And then we have cyst in the form of fluid-filled round ovoid cyst. I just want to emphasize in this that when we have a cyst in the breast, and in that cyst, if there is any intracystic nodule found, that cyst needs to be evaluated for ruling out malignancy. Now, coming to mastalgia, mastalgia is a very important and, in fact, the commonest symptom with which a female reports to a breast clinic. Mastalgia is also called as mastodynia. It is a universal phenomena for all women. It can happen at any phase of life, and it is said to be pathological when it exists for more than 7 days in a cycle, where the pain score is above 3 on a scale of 0 to 10 of visual analog scale, and this pain is interfering the routine life of the patient. In fact, breast pain has been classified as cyclical, non-cyclical, and extra-mammary cause. Here, through this right slide picture, I just want to show that when the extra-mammary cause is there, if you ask the patient to tilt laterally and keep all her breast tissue on one side, and if you just palpate on the region where she is complaining pain, and if you palpate and she mentions at this point is tender, most likely this is an extra-mammary cause. And also, if we squeeze the part of a breast tissue over here and then she complains of pain, then most likely the cause is mammary cause, not an extra-mammary cause. This cyclical mastalgia is very common in women of 30s. It is a dull aching pain which happens in bilateral breast, generally premenopausal, and this responds very well to hormonal therapies. While the non-cyclical pain is generally unilateral, and there can be some underlying pathology in the form of mastitis, abscess, or any complex situation. Whereas this musculoskeletal conditions, because of which the patient is apparently complaining of breast pain, there we can have unilateral or bilateral pain, such as, examples could be Mondo's disease, T syndrome, costochondritis. And in such conditions, treatment in the form of ibuprofen, aspirin, and other NSAIDs is very helpful. They respond very well to it. So the mammary causes, as I said, for the cyclical pain or for the cyclical or non-cyclical pain can be fibrocystic changes, mastitis, hyperplasia of breast, and in 2 to 7% cases, it can be because of breast cancer. The management of mastalgia, the most important thing is that the woman should wear a well-fitting bra, and in 95% of the women, within 3 months, she will report of improvement in the pain. In other conditions, intermittent analgesia, relaxation techniques, regular physical exercise, medication in the form of centroman with sahili, and supplements in the form of vitamin E, primrose oil, and flaxseed intake orally or maybe local application of flaxseed oil has been also reported in various trials to be helpful. There are other drugs like ormeloxifene and danazol, but these drugs, though they have symptomatic improvement, their patients do report symptomatic improvement, but it can be associated with the risk of other conditions happening. So the risk-benefit ratio is not good, and generally we don't prescribe that. Now coming to the breast mass. So a lady is coming with a lump. The lump could be a discrete lump. And the differential diagnosis for a discrete lump could be fibroadenoma, phylloids tumor, ductal papilloma, galactosele, and even breast cancer. Whereas when a lady is complaining of ill-defined lump, something like lumpy, bumpy feeling, where she squeezes her breast and tells me, I feel a lump in my breast, entire tissue, she tries to squeeze it. Basically, it is because of some cyclical nodularity or maybe fibrocystic changes. Fibroadenoma is the most common benign tumor. It is also called as breast mouse because it is extremely mobile. And these fibroadenoma have a tendency to increase in size during pregnancy, lactation, involution, and parturition. A fibroadenoma more than 5 centimeters in size is called as giant fibroadenoma. And fibroadenoma, a simple fibroadenoma, is without a family history of breast cancer, has no increased risk of breast cancer. But when the fibroadenoma is complex in the form of sclerosing adenosis or calcification or atypia, along with the family history of breast cancer, the relative risk increased 3 to 4 times. This is phylloids tumor, also called as cystosarcoma phylloids. And basically, you can see very large lumps. It can be unilateral, it can be bilateral, covering all the quadrants of the breast. And generally, what we find in such cystosarcoma phylloid tumors, that there is a prominent dilated veins can be seen on the breast, on the overlying skin. They can be, these patients are generally, axillary lymph nodes are not palpable in such patients. And there's basically a probe test. If you can see on the right side, this is a phylloids tumor, but it can also mimic with the fungating breast cancer also. Fungative breast cancer will also present like this only. But if we use a metallic sound or a probe and we try to put it inside through the margins of this lesion, in case of cystosarcoma phylloids, the probe will easily go inside, whereas in the case of fungating carcinoma, this probe will not go inside. and that is the probe test. Cystosarcoma phalloides is a recurrent condition. It's a recurrent problem. In fact, if you see this patient, this particular patient was operated 13 times for this condition, and eventually she died because of this condition only, because of the continuous recurrence. And this cystosarcoma phalloides have a tendency to become bilateral. And when we are finding all these lumps, we want to do the most important thing is the triple assessment. Now, triple assessment includes careful history, where we want to take the hormonal history, the relations with the menstrual cycle, the parity, the lactation, the family history. And apart from that, 3 assessments in the form of clinical breast examination, imaging in the form of mammography and ultrasound. Females over 40 years need mammography, females under 40 years need ultrasound, and histopathological assessment in the form of core needle biopsy. Nowadays, core needle biopsy is the investigation of choice rather than the fine needle aspiration cytology. And the combination of this, the diagnostic accuracy for triple assessment is as high as 100%. So we know that when do an clinical breast examination, one part of it is inspection, then followed by exhaustive and comprehensive palpation of the breast, not only the breast, but also other regions such as the axilla, the supraclavicular region, the infraclavicular region, the neck part of the region, and very importantly, the nipple areolar complex. Whenever we are palpating these women, it should be in a very systematic form so that all 4 quadrants of the breast are covered along with the nipple areolar complex. And many times it is common nowadays, and especially in Indian setup in young females, what we are finding is that females are not coming with breast lump, but with a large lump in the axilla. And by the time they come to us, this axillary lump, it means the disease has now become systemic. The disease has now become metastatic. Here you can see a 33-year-old female just after her pregnancy. In the late 3 years, the lesion start increases in her axilla. She kept ignoring it until it was very obvious and visible for her. And by the time she was diagnosed, it was already a metastatic breast cancer. On ultrasound, the lesions, the benign lesions usually look oval and ovoid solid mass, transverse in diameter, and with low level internal echoes, whereas in malignant condition, this lump has all forms of architectural distortion. The image is not clear, the image is not well defined, and we can have high level of internal hyperacoustic echoes. You can again differentiate. This is on the left side of benign lesion where there is architectural stability is there. There's lot of architectural distortion in the right one. And if you can see, there is calcification, which is visible on the right side, which is not seen in a benign condition. And when we do an assessment on the basis of imaging, ultrasound or mammography, the Byret's assessment is done, which is from 0 to 1, 0, 1, 2, 3, 4, 5, 6 categories. And here I want to emphasize that generally the Byret's 1 and the Byret's 2 category are essentially 0% chance of likelihood of cancer. And so such patients have to go in the routine screening of maybe 5-year interval or 3-year interval as per the guidelines. The Byret's 3 is the probably benign, where the malignancy is the probability of malignancy is less than 2%. But I want to emphasize that there are multiple factors in a female: her age, her menopausal status, her various other relative risk factors, her parity, and apart from that, her family history. All this can lead to accumulation and the cumulative effect of increased breast cancer risk. And such women should have short interval of follow-up in the form of 6 months to 12 months. Whereas when Byret's category 4 is there, especially the suspect, the 4B and 4C, where the suspicion increased from 10 to 94%, histology is recommended in all such lesions. And when Byret's 5 and 6 is there, the probability is as high as 95 to 100% of cancer. Here we need biopsy to start the treatment and the planning. It is also important because many of us live in the dilemma that I got a patient who has a BI-RADS 3 category lesion. Now, what to do? So this is as per the guidelines of the Radiology Association. They have stated that any BI-RADS 3 lesion should be followed for 2 years. It can be short interval follow-up of 6 to 12 months. And in that follow-up, if it is seen that the diameter of the lesion is increasing by 20%, then upgrade the category to BI-RADS 4 and send the patient for biopsy. But if the lesion is stable, it is not increasing in size, it is in same size, or maybe in fact regressing in the size, the category can be downgraded to BI-RADS 2 and the patient can be now in the routine screening. So whenever we send the breast lumps and the women, whenever we find women with breast lumps and we want to refer them to the experts who can take the biopsy, the breast surgeons, so they ask us 4 things. The 4 questions are: what is the age of the patient? What is the family history of this patient regarding breast cancer? What is her past history? Any history of lump excision, any abnormality findings on those lump excisions? And what is the present clinical and radiological characteristics of this lump? And these are the various criteria where the lump should be undergoing biopsy. Any lesion which is BI-RADS 4 and above, which has a tendency to grow, a new palpable mass in a menopausal woman, a mass in patient with high risk factors, and patients with suspected microcalcification on mammography. They all should go biopsy. Now coming to nipple discharge can be physiological as well as pathological. Physiological because of pregnancy and lactational status. Pathological can be because of the breast lesions, drug-induced, CNS lesions, basically pituitary and hypothalamic lesions, and various other medical endocrine conditions, in fact carcinoma as well, and it can be also idiopathic. And these are the various colors of nipple discharge that we see in our routine settings. Generally, bloody discharge is seen in ductal ectasia, even in cancer, in ductal papilloma. Serous discharge is mostly seen in fibrocystic changes. Color discharge is basically seen on brown color discharge is basically seen in ductal ectasia, and milky discharge is seen in the physiological galactorrhea and prolactin secreting lesions. And as we said, the nipple discharge, when it is physiological, all we need to do is just reassure the patient and send her back, no further evaluation. But if this discharge was unilateral from a single duct associated with an underlying mass or maybe bloody nipple discharge, then she needs to undergo the triple assessment. And this is the condition which we are worried about. A postmenopausal female, a 50-year-old female or above, who is coming with a spontaneous single duct and bloody discharge, which is positive on cytology, may be associated with an underlying mass. Such patients should undergo examination followed by a procedure called as microdocotomy. If you can see in microdocotomy, this entire lobule and the breast duct has been removed. And if you can see, the other important condition is the eczema and the Paget's disease. Now, they mimic with each other a lot, but the important differentiating features are that the breast eczema is confined to the areolar region and the nipple region is spared. While in the Paget's disease, it is the nipple that is involved and the areola is generally spared. And the other thing is that the Paget's disease, there might be some underlying condition, underlying breast mass, which is not in the case of eczema. Eczemas are generally bilateral, which is not in the case of Paget's disease. And eczemas respond well to antihistaminics and corticosteroids, which is again not in the case of Paget's disease. And we are all aware of this 1987 publication from the Lancet, where the first time the term ANDI was used. And this ANDI concept is basically telling that when a breast is developing in a female, there can be aberrations and there can be also disease. Aberrations are those conditions where reassurance to the patient and regular follow-up is all required. But disease is generally incapacitating and their surgical intervention and medical intervention will be required. And if we classify all these benign breast lesions on the basis of their malignant potential, the risk of breast cancer, Atypical hyperplasia, ductal carcinoma in situ, lobular carcinoma in situ have a very high chance of developing breast cancer, as high as 10-fold, 12, 13 multifolds. And whereas these conditions, fibrocystic changes, fibrosis, hematoma, phylloid tumor, ductal carcinoma, they generally do not have an increased risk. However, phylloid tumor may be, based on the histopathology, can be graded as benign, borderline, or malignant. And these complex fibroadenomas and hyperplasia with atypia, generally they have 2 to 4 times increased risk. Now coming to breast cancer, and I want to emphasize on as a public health person that breast cancer is the #1 cancer now globally, irrespective of the gender. It's the #1 cancer in worldwide, #1 cancer in Asia. 50% of the cancer that are happening in women is breast cancer. 50% of the mortality that are happening in women is because of breast cancer, in cancer-related mortalities. And same in India, breast cancer is the leading site of incidence for cancer and the leading site for mortality as well. In fact, if you can see, everything is pink over here. This is the world map. And out of 185 countries, 159 countries now report breast cancer as the #1 cancer. It has surpassed lung cancer in 2020. Now, 1 in 4 cancer cases because of breast cancer, and 1 in 6 cancer death is because of breast cancer. The estrogen receptor positive breast cancers are increasing over the period of time. This could be because of the obesity epidemic that is happening, and also because the mammography screening is more sensitive towards estrogen receptor positive breast cancers. And what we are seeing is that the transitioning countries, such as the African countries, the South Asian countries, the other Asian countries, and some high-income countries, such as Japan and Korea, where the incidence of breast cancer was low, in such countries, the breast cancer is rising, and the reason is dramatic lifestyle changes. In fact, the Globocant presented this data, and they said that in the next 20 years, the incidence of breast cancer will increase as high as 52% in India, and the deaths because of breast cancer will increase as high as 62%. And if you can look at this data, you can see that still right now, our age-adjusted incidence rate for breast cancer in India is still lower to US. US, it is 90, in India, it is 25. But if you can see at the mortality rates, they are comparable, somewhere reflecting that though we have lesser incidence, but almost very high mortality. And in fact, from various tertiary cancer centers, when the audit was done, it was found that the 5-year survival of such patients who were early breast cancers was as high as 95%, while the late advanced breast cancers, the survival was as low as 21%. And the population-based cancer registry data from Madras and Bangalore have stated that overall survival is just 50% for women with breast cancer. Why this is happening? If you can see in this data, this is a very recent data presented in DCO Global Oncology in 2020, and they reported that still in India, 60 to 70% patients are still diagnosed in local, regional, and advanced distant metastasis stage. Only less than 30% women are diagnosed in an early stage. And also, we are facing a double bimodal epidemic of curve with regards to the age of the patient. We are seeing one peak at the age of 30 to 44 for breast cancer, and again one peak at the age of 50 to 64. And very important entity among this is triple negative breast cancer, where the breast cancer is not expressing estrogen receptor, progesterone receptor, and human epidermal growth factor receptor, which is HER2. These are 50 to 20% of all the breast cancers. They generally happen in younger females, mostly in Asian and African population. They are more aggressive and have poor overall prognosis and very high recurrence risk. And in India, this was a study done, and it was shown that among all the Asian countries, India has highest reporting of triple negative breast cancer, much higher than the developed countries. And the reason is the lifestyle changes that are happening, the family history, the high mitotic index, and BRCA mutation that are seen. The problem with triple negative breast cancer is that it greatly hampers the lack of the targeted treatment that is available for receptor positive breast cancers. And generally, these triple negative breast cancer are younger females who have higher histologic grade and are associated with lymph node positivity. So actually, by the time these triple negative breast cancers are diagnosed, many of them become metastatic and systemic disease. In fact, the study from Pune has shown that almost 57% of the women who were of breast cancers, they were basically triple negative breast cancer. This is the reporting data from 2018 from our Tata Memorial Center, Varanasi, where we reported that 24% of them were triple negative breast cancer. When we talk about the risk factors for the breast cancer, they can be easily classified into relative risk factors and absolute risk factors. And the relative risk factors include in the form of late parity, early menarche, late menopause, postmenopausal obesity, sedentary lifestyle, smoking, alcohol. And important is the absolute risk factors in the form of, as I said, any woman with a history of hyperplasia with atypia in her previous breast lesions or in her current breast lesion, along with a strong family history, first degree relatives, mother or siblings having breast cancer, that too at a very young age in a premenopausal stage, is an absolute risk factor. And those women who are detected with BRCA1 and BRCA2 mutations, those women who have received chest wall irradiation, maybe because for Hodgkin's disease or maybe for thyroid cancer, they have received therapy treatments for radiation therapy. Such women need to be in a regular surveillance for breast cancer. These are the various risk estimation models. We all are aware of that: Gale model, Bodesia, Claus, BRCA Pro, and they require all these variables information for understanding the risk estimation model. However, to date, none of these models are useful in an Indian setting. The other entity apart from triple negative breast cancer is the BRCA mutation that we are worried about. Familial breast cancers comprise 10 to 15% of the breast cancers, and we find prevalence of BRCA1 mutations as high as 28% in these. BRCA1 mutations are most common in women compared to BRCA2. And generally, this young triple negative breast cancer women have propensity to have BRCA1 mutation. This is a very large study done by Global Burden, and it was published in the Lancet Global Health in 2020. And what they stated was that the postmenopausal breast cancers are increasing in countries with socioeconomic transitions, such as South and Eastern Asia. So basically, they were saying that in India, the postmenopausal breast cancers are increasing. And then very important aspect is the role of the relation of the menopausal hormone therapy with breast cancer. Now, I'm quoting the data from Women Health Initiative data, which is a large population cohort of over lakhs of women who were having breast cancer. They were followed for several years. This is basically meta-analysis data. And what they have said is that every menopausal hormone therapy type, except for the vaginal estrogens, are associated with excess breast cancer risk. The relative risk for combined therapy, both estrogen and progesterone, has greater risk compared to estrogen alone. This risk increases with the duration of the hormone therapy received by a woman, and this risk will persist in women who have taken it even as long as 10 years after stopping this hormone therapy. And the current users of hormone therapy have an increased risk compared to the past users. The silver lining in this is that generally these cancers are invasive lobular and tubular cancers, which are more strongly associated with hormone therapy compared to the invasive ductal cancer. And we know that lobular and tubular cancers are more likely to be receptor positive, and so they may have better treatment outcomes. And they also interpreted that if a woman takes 5 years of menopausal hormone therapy starting at the age of 50 years, they would increase the risk of breast cancer incidence at the age of 50 to 69 years by about 1 in every 50 user who is using estrogen and progesterone, but the progesterone preparation is a daily preparation. And 1 in 70 users in the estrogen and progesterone preparation where the progesterone preparation is intermittent. And 1 in every 200 users where estrogen preparation is alone taken, not progesterone. And this corresponding excess that is being shown over here, this increases from 10 years, it increases to double times when the hormone therapy has been taken for 10 years. And these are the important risk protective factors for breast cancer: vigorous physical activity, having childbirth at a younger age, 12 months of breastfeeding, decreased fan ticket, and increased vegetables and fruits. These are important protective factors for breast cancer. Now, coming to some topic which is very close to my heart, the prevention and control. We know the risk factors now, but the very important part is the screening and early diagnosis of these women. Screening, we know, is generally done in females who are apparently healthy, whereas early diagnosis is done in females who have symptoms. World Health Organization has defined early diagnosis as detection of symptomatic breast cancer at an early stage. Why we want to detect women at an early stage? Because it is potentially curable, it will offer better survival to the woman, lesser treatment-related morbidity, better quality of life, and also lower treatment costs, which is so important in our Indian settings. And that's why in our community, in our OPD setups, in the in-house hospital services, we ensure that we educate all women regarding the important early warning signs of breast cancer. We show them these graphic pictures and make them explain. Nowadays, we have also started doing and giving this education to young girls, adolescent girls, so that they know about breast awareness. Breast awareness is so important, to know your own breast, and which can be done only when it is done regularly, every month. So we educate our community that they should undergo breast examination, which should be done every month on the day 10 of her menstrual cycle, and for the postmenopausal female, on any day that she has decided, any fixed day, first day, last day, whatever day she decides, but it should be done every month, followed by clinical breast examination and imaging. This is the picture we often show to our community females, how to do breast self-examination in the form of inspection and palpation. We tell them that you should not miss all these important parts such as nipple areolar complex, the axilla, the neck, along with the breast. Now, coming to something which is very important, which is clinical breast examination. In a country like India and in many other countries, low resource settings, where there's low resource settings, clinical breast examination is the screening method of choice for population-based screenings. In fact, 2 trials from India, namely the trial from Tata Memorial Hospital, Mumbai, and from the Trivandrum Cancer Center, what they have found is that, and these are population-based trials, what they have found is that clinical breast examination helps significantly in downstaging. So it is very important in our study settings. Mammography has shown its effect in high-income countries by 20% mortality reduction for women who were invited for mammography. But it is important. But mass screening with the help of mammography is optimal for high-income countries, not for countries with lower middle income. And in fact, mammography is not sensitive for Asian population, for younger females. Why Asian population? Because Asian females have denser breasts. So mammography in those patients, the sensitivity drops from as 98% to immediately 48%. And even in the young females. The other problem is overdiagnosis, which is associated with mammography, and the cost of the equipment. Same thing is with ultrasound. Ultrasound is still better than mammography for the Asian population. But again, because of the PCPNDT Act in India, it is difficult to use portable ultrasounds in the community for screening for any breast cancer program. And nowadays, there's a lot of talk about artificial intelligence. So I just wanted to emphasize that no matter how many studies that are undergoing right now for artificial intelligence, at present state, artificial intelligence is helping only the clinicians to make diagnosis of breast cancer. They are not the replacement for clinicians, and they're just helping in decreasing the reading time of an ultrasound or mammography. MRI is important for females who have hereditary breast ovarian cancer syndromes, where there is BRCA mutation, where there's high familial risk. In such women, young women, it is advised, and this is the advice given, consistent statement given by the Indian Council of Medical Research, that young women should young women should undergo screening with the form of MRI for women who have high risk of familial risk of developing breast cancer, and they should start below 40 years. Basically, depends upon in the family. If the mother or sister has developed breast cancer in the age of 50, the woman should start her screening in 40 itself. But if the woman has developed, the family members have developed breast cancer in their 30s and 40s, minus 10 years, she should start getting screening done. And this screening should be done every year. The Government of India guidelines for clinical breast examination and imaging is every 5 years, while for MRI, it is every year. And the important thing is that MRI is expensive and it cannot detect ductal carcinoma in situ. CT scan and PET scan are important evaluation methodologies when the breast cancer has been diagnosed, basically to evaluate the distant metastasis. And these are the various national and international guidelines given for the clinical breast examination. Some are overlapping, some are contradicting, but in the Indian settings, it is said that the Government of India says that any woman in the age group of 30 to 65, she should undergo clinical breast examination every 5 years. And the National Cancer Grid states that apart from clinical breast examination, if the settings is supporting mammography or imaging, it should be added and it should be done every 5 years. This was a systematic review done by the authors for various important trials that were done for clinical breast examination as a standalone screening. And what they found was that in all these trials, a well-performed clinical breast examination can achieve the same effect as mammography, despite lower sensitivity for mortality reduction. In fact, they found that it has greater sensitivity for younger women and Asian women. And clinical breast examination significantly contributed in 17 to 47% downstaging of the breast cancer. So the younger we catch the female in the earlier stage, the better is her prognosis and life. This was that landmark screening trial done from Tata Memorial Hospital in Mumbai, where they had enrolled more than 150,000 women. They followed them up for 20 years. The intervention was clinical breast examination versus as a standalone screening modality. And what they found was significant downstaging, along with 30% relative reduction in breast cancer mortality in women who were 50 years and older. The Government of India is dedicated towards the prevention and control of breast cancer in the form of National Cancer Control Program, which has now changed to NPCDCS. Government has laid down guidelines. Government is establishing so many cancer centers across India for basically making cancer care approachable and accessible. These are the various guidelines provided by the national health programs. These are the various guidelines given by the National Cancer Grid for low resource and high resource settings. So guidelines are everywhere, but still we are getting females with us in this condition. It's a routine thing, 1 or 2 cases we see, and it is so painful to see women in such conditions, especially the elderly females that come to us, and we feel so sorry for them. What we want is that they should come in this form where there's an early breast lesion. And the reason for this delay in diagnosis, in fact, the delay in diagnosis was calculated by several studies from India, and it was stated that it takes 6 to 9 months to get a treatment started in a female who is diagnosed with breast cancer. These delays are not only because from the patient end, but also from the provider end. From the patient end, the reasons can be in the form of stigma, in the form of poor health awareness, in the form of lack to access to care, in the form of previous past trust issues in the health system. And in the health system, the reasons for these delays could be poor infrastructure, lack of trained manpower. In fact, this problem is not only limited to early diagnosis of breast cancer, but also for the treatment, where we have seen that in the peripheral healthcare, the practitioners who do not have an oncology expert background, often they leads to mismanagement of the breast cancer. These patients, and most of the times what we find in a tertiary cancer center, that the patients that are referred to these epic centers are basically in a palliative stage. And by the time these patients come for the treatment, they have exhausted all their financial resources. They have given everything out. They have sold everything. Now they don't have enough money to further continue the treatment. So to conclude, opportunistic screening is currently active and should be fully utilized and aimed towards program-based screening. Mammography screening program may not be cost-effective or feasible in our Indian settings. Clinical breast examination is probably the most important way of screening for our population. Women with high risk must be categorized and they should be kept in close observation by regular follow-up. Majority of the breast lesions are benign and we need to reassure these patients, but we also want to rule out breast cancer. Reassurance is very critical to allay the fear of these patients. Surgery is required in very few cases of benign breast disorders. Surveillance of such women, especially with high risk, is an absolute must. And this is very important that while we are promoting early diagnosis and early detection and breast cancer awareness, we also need to ensure that the women who are diagnosed with breast cancer, they should be timely treated and appropriately treated at the centers in the timely manner. And so that is why we don't want this, that we expand cancer awareness and early diagnosis programs, and we are not preparing them in the form of expanding the diagnostic and treatment facilities, because this will only result in increased number of women with disease, but not able to get the treatment. And once this happens, this will further add to the mistrust in the public health system, and they will rely more towards the unorthodox system where they will be poorly managed along with high treatment cost. So my take-home message is that every woman who is eligible for the breast cancer screening must undergo clinical breast examination for any condition where she's coming, and she should be it should be done by any trained healthcare provider, and we should not miss any screening opportunity. Thank you so much.
Thank you, Dr. Divya, for this extensive lecture. I must congratulate you because you covered all the aspects of the prevention and screening and how to identify benign and then cancer and everything, even the government programs which are running to curb the breast cancer. So I must congratulate you. I would request Dr. Ranjana Khanna ma'am to give your expert comments and to summarize the scientific event.
Dr. Divya, that was a very lovely detailed description, and I think all of us thoroughly enjoyed it because it was a sort of a revision class for us. I was remembering all the pictures of Love and Bailey and went back to Professor Tarachand's class, and so it is always very good to revise anything which we were taught earlier back. But you know, one thing which I wanted to stress, Divya, is that still we are very lacking in awareness of breast examination. And every girl, every mother should be explained, even if she comes to the clinic, that tell your daughters, and you should also be aware, stand in front of a mirror without your clothes before having a bath. Just see your breast first. It is such a taboo thing in our culture to see your breast. So that is why people don't want, you just just see your breast, visual inspection. And on the 1st of every month, just see it again. Do you find anything abnormal? Is there a wrinkling? Is there a dimpling? You find some protuberance, then immediately just palpate it lightly and go to a doctor. But this is missing, and you'll be very surprised when I tell you something, that it's not only in the rural settings. It is very much in the elite class also, because I was shocked. This time I met a gynecologist. She is around just 5 years younger to me, and she was telling me that I won't tell her name, she's a breast cancer survivor. So I said, okay. And then she told me that she was diagnosed just 2 years back in stage 3B. I said, how come? You didn't realize? Kathy, I had no symptoms at all. I used to never touch my breast. And then once accidentally, at night, I was just sitting in front of the TV and they started telling about self-breast examination because one of the children just changed the channel. And then she started seeing, and accidentally I just put my hand, flat of my hand on my left breast and I felt the lump. And I said, what a fool, I have got a lump in my own breast and I'm not bothered. She had no symptoms. She had never touched her breast. And then it was, and then the very next day she went for examination and it was diagnosed as stage 3B. So what I want to stress is that we as clinicians have to become aware first before we impart this knowledge to our patients. We have to tell our patients because that is the only way we can control this. People are coming at a very late stage in cancer. And I feel what the incidence that you've given for that 25% in India breast cancer, that is because it's not being diagnosed most of the time. The villagers are not coming. They die at home only with the breast cancer and nobody comes to know that they had breast cancer. So it's not about that. I think it is just underdiagnosed because healthcare sector is still very lacking in India. And what is very, very lacking is the public awareness. And very clearly you have said under 40, it should be ultrasound and above 40, it should be mammogram. And beautifully told and points have been well taken, Divya.
Golden words, ma'am. Golden words from you. Thank you so much, ma'am.
Thank you, Ranjana ma'am. Thank you, and very correct you are that we are lacking the public awareness basically. And I request Dr. Divya, you please highlight at what age a girl should start her breast examination because at this tender age when she's in teenage, she's very unwilling to look her into the mirror, to touch her breasts.
She said that minarchy, no? She said that minarchy.
Yes, ma'am. Any adolescent girl who started menstruating should be aware about
Yes.
Yes.
Menstrual history and all, everything should be explained
to her. That is the right
to
time to motivate a girl. That's the right time, at the time of menarche.
Yes.
Thank you so much, Dr. Manju Verma ma'am, for giving me this opportunity to be part of this program. And I really enjoyed your talk, Divya. You just take after your mother, Dr. Anuradha Khanna.
Thank you, ma'am. Thank you.
A great comment and best wishes. So as Dr. Veena Gupta said in the beginning, I would request Dr. Kirti Dubey ma'am to bless us with your words and about the lecture, give your comments. Yes, ma'am.
At the outset, of course, Divya, you have been really so informative and as truly said by Dr. Ranjana that you have really revised and all the more sensitized to gynecology.
Ma'am, आपने 2 डिवाइस से ज्वाइन किया है शायद तो वो इको कर रहा है.
इको कर.
एक डिवाइस से ऑफ कर.
आप लैपटॉप से.
अच्छा, आप दोनों लोग डॉक्टर ताराचंद को याद कर रहे हैं.
बहुत याद कर रहे हैं, बहुत. Actually, what I want to say to all gynecologists, of course, it's going to be very cumbersome. That why do we not examine the breast when we are examining the patient who is coming to us for a gynecological problem?
Yes.
But you know what will happen, Kirti? The patient will say, "There's nothing wrong with my breast. Why are you touching this?"
Why you are touching? They object.
Tell them. That is also very much needed. Like in antenatal patient, we examine the breast to see for retracted nipples.
Yeah.
Early when we are doing before we do a pervaginal pulse speculum, why not start from the breast? And that is how we can just make it. We can create awareness. That
of course,
is also very important.
Of course,
it was really very nice. I loved hearing you. And of course, the core biopsy is really a thing which I think all of us should know. Instead of sending for FNAC, a core biopsy is the needed thing nowadays. And the ultrasound for small lesions rather than sending them for mammography, which they cannot afford. Thank you so much. Thank you, Dr. Anuradha. Thank you, Dr. Manju, for making me a part of it. Of course, this is my
Ma'am, you are very much a part of UPCOG, ma'am.
Yes.
Can I say something if you give me a chance to
Yes, ma'am. Now I request Professor Seema Haki ma'am to say a few words for us.
Well, I'll be speaking with my camera off because some technical issue with my camera. I would like to say two things first. Divya, you are the one who, I am one of the few who saw you first at your birth.
Oh,
that is one landmark. Like I was JR1 and Anuradha Di was Professor D. Sharma's patient. She operated upon her. The other thing which I learned at your birth for my life, and I still practice it from Professor D. Sharma, was early ambulation. So actually, Professor Anuradha Khanna was up and about within few hours of her delivery, and she was having her meals. So that time, the concept of early ambulation was actually very rare to be known by people. Am I right, Professor Anuradha Khanna?
Yes, you are very right.
That concept I learned during my first year residency. And I always practice that concept. And my patient asked, "Arey, aap itni jaldi utha rahi, hamare sab taake toot jayenge." Humne wo kabhi nahi toote. So that was a landmark learning point for me. About your talk, I really thoroughly enjoyed, and it was a talk very well prepared, I must say. Because on each slide you need
Something wrong.
क्या हुआ?
Net issue.
आवाज गई.
Seema ma'am, your voice is not.
Slides were there, which were, as Professor Dr. Anjana Khanna said, love and Bailey pictures. So that was very important. Another thing which I learned for my life during my first year of residency is whenever we used to see any antenatal case, 3 examination used to be must. Without that, Professor D. Sharma really used to scold us. CVS, chest and breast. तो वो चीज जो हम लोगों ने तब सीखी वो हमेशा के लिए है कि सीवीएस चेस्ट एंड ब्रेस्ट एग्जामिनेशन के बगैर कोई एंटीनेटल एग्जामिनेशन नहीं होता है, चाहे वो पहली विजिट हो, first trimester ki visit ho, we always used to see. And of course, all the abnormality you detect during breast examination. Another thing, as it was said that in elite group, we see carcinoma breast very frequently, and it is right. One of the medical student who lost her mother at a very, the mother was young, and she was diagnosed at an advanced stage of breast cancer. Being in the family of doctors, if somebody is getting diagnosed, that means somewhere we are lacking. So more awareness is needed for breast examination. Sometimes, you can miss the cell breast examination, a very small deep-seated lesion can be missed. So those having family history or with any apprehension of breast cancer, I think they can have USG breast, which should be done. One question was lying in the chat box. I don't know whether you will be able to answer that or not. What is the treatment for fibrocystic breast disease? Anyone can answer here if you like, expert. The other thing is, what should be done if somebody in the puerperium, immediate puerperium, has fibroadenoma breast and it is giving rise to very painful lumpy breast. So one of my known, recently she delivered and the baby was just a week old and she started getting so much of pain because of fibroadenoma breast during breastfeeding that she has to stop it. And that was the saddest part, because doctor gave her breastfeeding for suppressing breast milk. So these are the problems which as a gynecologist we see, and we have to give answer to our patient, as most of the cases their primary caregiver is most of the time obstetrician and gynecologist, because they think that ये female की doctor है तो हमारा breast यही देख सकती है. दूसरी चीज, जब हम लोग थे तब mostly surgery was a dominated field by male surgeon. Again, I am really happy to see that more and more girls are these days joining surgery, and really they can do much more than the male counterpart surgeon, because female are more comfortable showing to a female surgeon. So, and we have very few, even in medical college, we hardly have 1 or 2 in our medical college, we have only just one female surgeon. So more and more girls should also join surgery to take care of female breast. Thank you very much for giving me this opportunity, and it was a wonderful program. Though I was busy, but I never switched off my device, and I was continuously on, and I listened to all your talk, and especially I really like, because eczema and Paget's disease we see, and the difference was really nicely explained. Thank you very much.
Thank you, ma'am. Thank you.
Oh, thank you, Siva ma'am. Thank you for your very comments, and I think everybody have some story about the breast cancer in their family or friend circle or vicinity, because it's so common nowadays. And it is really very important to emphasize upon self-breast examination and clinical breast examination. So thank you so much. Dr. Bharti Maheshwari have written in the chat box that she had to attend some other meeting, so she left. And Dr. Priyanka is there. I think she's also not there. So, Verma ma'am.
Vote of thanks.
May I invite Ramit for vote of thanks?
Thank you, ma'am.
So I request and I invite Ramit, Dr. Ramit Ahuja, to give vote of thanks.
Thank you, Dr. Amrita ma'am. I take this wonderful opportunity to extend my heartfelt thanks to all the great stalwarts, Dr. Padam Shri Dr. Raj Baveja madam, Padam Shri Professor Dr. Usha Sharma madam, teachers of teacher Dr. Chandravati ma'am, and teachers of teachers and talks chief patron Dr. Meera Agnihotri madam, for their unrelenting support over the years to our state organization of UPCOG and their blessings in today's webinar. I'm grateful to the present office bearers of UPCOG, Dr. Anuradha Khanna madam, Dr. Kirti Dubey madam, Dr. Seema Hakim madam, Dr. Bharti Maheshwari madam, and Dr. Priyanka for their good wishes for today's program. I thank our chairperson for our scientific deliberation, Dr. Manju Shukla madam, Dr. Radha Jina madam, and Dr. Ranjana Khanna madam for their expert inputs. I thank our learned speaker and showstopper of today's session, Dr. Divya Khanna, for highly enlightening us on the topic, for which she deserves a big round of applause. I extend my special thanks to Dr. Professor Dr. Manju Verma madam for taking out all the pains for the conduction of today's program and for being always there as guide and support for all of us. Thank you so much, madam. And I also thank my wonderful senior, Dr. Amrita Chaurasia madam, for all the great support and help she has been providing. And I thank Dr. Veena Gupta for all the help. And I also thank all the delegates for taking out time from their busy schedules for logging in for this webinar. And I thank our pharma company people, Walter Bushner, for all the technical support for the smooth conduction of this webinar. So thank you so much, everyone. And today only I saw this case of sarcoma phylloides. And today we have, tomorrow we have planned a case with my oncologist. And she's just a 16-year-old girl.
Oh my God.
In her FNAC report, she came from somewhere and it was mentioned sarcoma phylloides. At such a small age, this girl came. And let's see.
So she might be BRCA positive.
Positive.
Yeah. Let's see what happens tomorrow.
Mr. Brijesh, would you like to say something?
Thank you, ma'am.
Mr. Brijesh, would you like to say something?
Madam, आपकी आवाज पूरी आई, हम लोगों ने आपको पूरा का पूरा सुना है.
दिव्या,
नहीं, तालियां भी बजाई हैं.
Thank you so much. Thank you so much.
Thank you, Manju ma'am.
Divya,
Thank you, Divya ma'am. This is Ranjit ma'am, marketing head Walter Bushner. It was great to be the part of this program. A very noble topic we touched upon. Thank you. And Walter Bushner always stands committed to get associated with such kind of scientific session, ma'am. Great to you all.
Thank you. So I think the webinar is at the end. And I must like to thank everyone, and Divya, I would like to congratulate you.
Thank you so much.
such a nice and crisp and clear with picturesque deliberation. So I think I should say bye-bye to everyone, and I think we can leave now.
Thank you, ma'am. Have a nice evening.
Thank you to you
Thank
all,
you, ma'am.
your team, to
Thank
your
you.
team, Dr. Bushnell, for the support. Thank you. Thank you.
Always there for you, ma'am. Thank you. Thank you, the entire team. Thanks.
Thank you. Namaste, ma'am.
चल गुड ब्रिजेस, गुड सो
थैंक यू
बढ़िया रहा ना, समझ गया कैसे करना है पूरा?
अरे सर एकदम समझ गया, मजा आ गया।